So I was starting to get concerned, knowing now that this child is CRIM negative, what do we really do? So we discussed, and Dr. Mendelsohn was brave enough and said, let's try immune modulation. And that's what she did. She used an agent called rituximab, and then she later used an agent called methotrexate. And these have been used either in the cancer setting or in other settings where people make high antibody titers. And this is the kind of response that we've seen. And I really think this is pretty groundbreaking. I have to admit this is an n equals 1. But this is quite dramatic to see. This is the antibody titers of this child on the enzyme. And this is after the start of rituximab right here. You can see that the baby has come down in terms of its antibody titers. It's normalized and continues to stay in the normal range. This baby is now 26 months old, continues to be antibody free. And we know that this is not what we would expect in a typical CRIM negative child without therapy. So this is just the details of the protocol. And I want to point out is we were very careful in the kind of dose that we were using, very low dose of the methotrexate, because yes, these are children. And there were really no safety issues that we had with this one particular child in terms of infection risk or immune suppression. And this is the video of this child that Dr. Mendelsohn shared with me. And anyone who's looked after a CRIM negative baby, I think, would recognize that this is an achievement. This child is, yes, on a ventilator, but is on very stable ventilator support, is continuing to gain motor milestones, is sitting, kicking its legs, moving its lower extremities, which we do not see in a CRIM negative over the course of time, and reaching out for objects, signing, and continuing to make progress. So I think this is the beginning of hope. And this is just comparing this baby to what we've seen in other CRIM negatives to drive the point home. Of the 11 CRIM negatives that I'm aware of, who were at a similar age as this baby, 9 of the 11 had died at 27 months, and the remaining 2 were on invasive ventilation with clinical decline, as compared to this baby, who's now continues to be alive at age 26 months with stable minimal ventilatory requirements and continued clinical improvement. And if you look at the antibody titers, at 25 months, titer in a CRIM negative, 1 in 409,000 negative in this baby. So this is quite dramatic, and this is once again showing you the motor development in this child, and the left ventricular mass, even that has continued to show improvement. So we think that we've got some hope here. And so these are the active protocols that I just wanted to bring to your clinical attention. The CRIM negative naive patient, never been exposed to enzyme, patients who are mounting an immune response irrespective of CRIM status, please contact Genzyme or members of the Duke team, especially for the infants, so that we can help guide these families to be able to manage. So to my knowledge, this is in the United States. I'm not sure of what sites are in Europe, but I thought that I would bring this up. And in terms of long-term issues, the patients really keep us humble and straight. What else is going on with the children? I really want, and I don't know if this will come through, but there is hypernasal speech in infants with Pompe. I don't know if you can hear this. I don't know if you can hear this, but
very good. And say for me, buy baby a bib.
Do you see that?
Good
There's
job.
hypernasal
And say
speech.
for me, take it to Ted. Very good. Say, I like cookies. Cookies, very good.
All right, and here is a baby that was started at 15 days of age on enzyme therapy, and you can see the difference. You can't hear this. Oh.
Oh, is the bike stuck?
That's Laura, by the way.
Laura? It's stuck. It is stuck. It is stuck. You think we can fix it?
Mom got it.
You got it?
Mommy got it.
And here is a baby who was started at 7 months.
Nice.
Dakota, can
If
you
you just
say
wanna-
hi to, can you say hi,
Okay.
Dr. Kishnani?
Can you say Mommy?
So just to show you that there is a difference when you start therapy, even as we're seeing in the infants. And then ptosis, which is a weakness of the eye muscle, has been recently recognized in adults with Pompe disease. And I want to show you a child on enzyme therapy doing very well, but as you can see now developing ptosis of the eye, or the drooping of the eyelid, as you can note over here. And this is her at age 5 years. She's continuing to walk, but as you can see, she has the classic drooping of the eyelid, this one much more than the other. And we should have recognized this. This is our very first baby, John Consul, the very first baby that was treated with enzyme therapy, and he was CRIM negative. So a lot of tribute to this boy. He taught us so much through the years. And I'm actually amazed at myself how I missed this finding. It's so obvious now in retrospect that this boy was developing ptosis, as you can see, with real drooping of the eyelids over the course of time. And I think, Laura, you showed this yesterday, right? The next. Okay, so to say that we are seeing some similarities between the infants and the adults. So yes, there's a lot of learning that we can have from the infants. Look at the neck weakness in this child who's ambulatory. Do you see that? So you can miss it if you don't look for it. This is the oldest survivor, the first infant. Also, you can see some weakness. Here's a little girl also showing the weakness. And here is an adult, just to say that we are learning from both ends. And once again, to show you that there are some difficulties that we are seeing between the infants and the adults. A little girl who's ambulatory, but you can see has difficulty with standing, with getting up from the lying down position. And I'll conclude. So the question was, is 20 milligrams per kilogram every 2 weeks appropriate? I think, once again, this is what we call customized or personalized medicine. I think some patients may need more. And I know that in our initial study, we said there was no difference between 20 and 40. And some may need less. I think Laura showed you some videos of a patient who was on the heavier side. So we based her on ideal body weight. And we have now 5 like this who've actually done pretty well on ideal body weight of 20 mg per kilogram. And so if I tell you this is a young boy. I think many of you know him. This is before he started enzyme therapy. Just focus on the eyes. This is when he got his first infusion. And once again, note the eyes. He's got a drooping of the eyelids, a drooping of the eyelids, a drooping of the eyelids. All this was on 20 milligrams per kilogram. And now see him. This is a few months on the 40 milligrams per kilogram. He feels much better, but clearly you can see that there is a response right here. So to tell you that I don't think we can generalize that 20 is the standard dose, I think we've really got to look at every patient individually and see what it is. And this is what it takes, a team to succeed. This is the day after we celebrated, where we had 70 families with Pompe come to Duke for our reunion. And this is all of us in a more light mood. And the patients really keep us humble and are our best teachers, I feel. This little boy would have never made it into the clinical trial just because of how large his heart was, and he was such a high risk for anesthesia. This little boy died because the physician would not intubate when he was back home, and so he died, had a cardiac arrest and died. This little girl died of anesthesia before she started therapy at Duke. And of course, this little boy is now doing so well on therapy, celebrating a birthday. And this one is the one I showed you playing basketball. And these are from the original cohort. So this is the one who's been on therapy for the longest. He's 9.5 years. And these two are 8.5, close to 9 years of age. Of course, these are taken when they were much younger. They continue to do well at school. This little fellow is bilingual. I actually met him last year at a conference in California. And I stand here really as one of many, many people that has done this work, not just at my institution, but I would say throughout the world, multiple investigators from different parts of the world that have participated.